we are excited to have with us Dr. Pierluigi Mancini. He is project director of the National Latino Behavioral Health Association. A little bit of background on him. He funded Georgia's only Latino behavioral health program in 1999 to serve the immigrant population by providing treatment in English, Spanish, and Portuguese. He's the immediate past president of the board of the National Latino Behavioral Health Association and is recently named to SAMHSA's National Hispanic and Latino Addiction Technology Transfer Center Advisory Council. His co-presenter, Maxine Henry, the associate director of the National Latino Behavioral Health Association, unfortunately had a death in her family, and she is not going to be with us today. We're very sorry to hear that, but Dr. Mancini is going to do the presentation. We have him until 2 o'clock, and I've asked him to come talk about reaching and treating Latinx and in immigrant populations, the language barriers that are sometimes inherent in that, and what the best effective strategies are, and how the Latinx community has been affected by the opioids epidemic. So Dr. Mancini, I want to thank you very much and turn it over to you right now.
Excellent, thank you. And hello, everybody. Thank you so much for having me here today. I'll jump right to it. I'm going to be sharing the presentation on the screen, and hopefully you can all see that right now. So I think I had a pretty good introduction, so I'll move on to some housekeeping. There's going to be, you all can have access to the slide deck. However, Chris can get them over to you. There will be a brief survey at the end that we hope you can all fill out, because that helps us fulfill our mission. So our center is housed at the National Latino Behavioral Health Association, what is a nonprofit organization located in New Mexico. And the mission is to influence national behavioral health policy, eliminate disparities in funding and access to services, and improve the quality of service and treatment outcomes for Hispanic Latino communities. Our director is Fred Sandoval, and these are the 6 objectives that we focus on. As you can see right there, third from the bottom, is the opioid crisis in the Latino community, along with all the other issues. If you're not familiar with the technology transfer centers, the addiction technology transfer centers have been a part of SAMHSA for over 27 years. But 3 years ago, SAMHSA expanded the program. So now, besides addiction technology transfer centers, we have prevention and mental health technology transfer centers. And these are regional centers in the 10 HHS regions of the country that provide free technical assistance and training to behavioral health and prevention providers all throughout the country. It used to be you had to be a SAMHSA grant recipient to access them, but now it's open for everybody. And there are 3 national coverage centers. Ours is one of those. So we have the National Hispanic Latino, ATTC, PTTC, and MHTTC, and we serve all 50 states and all territories. There is also a National American Indian and Alaska Native National Center that serves addiction prevention and mental health. And we have a National Coordinating Council, coordinating office that keeps an eye on all of us and helps us fulfill our mission. The mission of our center in particular is to provide high quality training and technical assistance to improve the capacity of the workforce serving Hispanic Latino communities in behavioral health, treatment, prevention, and recovery. We disseminate and support that implementation of evidence-based and promising practices to enhance service delivery, promote the growth of a diverse, culturally competent workforce, and bridge the access of quality behavioral health services. And we're committed to increasing health equity and access to effective, culturally and linguistically grounded approaches. And you'll be hearing me talk more about that in a minute. We basically help organizations that are already serving Hispanic Latino communities how to do that better. And we help organizations that want to serve Hispanic Latino communities, help them set up and begin to provide those services. We're a small team, so I am the director of the addiction and the prevention technology transfer centers. And I have Maxine is my co-director, and Ruth Yanez is our executive administrative assistant. Okay, so when Chris asked me to do this, I said, well, let me begin just to make sure we're all on the same level and set the foundation for defining what it is that we're talking about when we talk about Latino, Hispanic Latino communities. And the issue that comes into play is that it is not a homogeneous group. There are people that come from 22 Spanish-speaking countries, 3 Portuguese-speaking countries, and the United States. So we have people that identify as Hispanic and Latino that come from all of these places. And the terminology can be problematic sometimes, because what do we call each other? Hispanic, Latino, and now there's Latinx that you're seeing all over the place. And the reality is that when you ask an individual, they are going to identify themselves by, most of the time, by country of origin. So I'm Argentinian, I'm Colombian, I'm Mexican. But if you ask a community, you do see some differences. So for businesses, we usually see Hispanic. So there's the U.S. Hispanic Chamber of Commerce, and here in Georgia, we have the Georgia Hispanic Chamber of Commerce. And for social services organizations, you usually hear Latino. So we have Latin American associations and Latin centers and so on. And then this Hispanics born in the United States also present, or Hispanics in the United States also present a challenge about identification, because you have different levels of acculturation within this population. And some are bilingual, some speak only English, and some speak only Spanish. So we have to be able to understand those. And then to wrap all of that, if it wasn't complex enough, we have the cultural groupings that make our community identify with any race or ethnicity. So we have Afro-Latinos, we have Indo-Latinos, we have Asian Latinos, and European Latinos. So chances are there is someone in Latin America that looks just like you. So we don't have markers of race and ethnicity in our community because we truly represent the entire spectrum. So when we're doing something to serve Hispanic Latino communities, we have to take those issues into account. I also want to provide some, a little more detail as to who it is that we are. So in 2018, 313 million, 44,728,000 were foreign-born Latinos. And half of those were from Latin America. And we have the second largest group is Asia. So in Latin America, we have English, Spanish, and Portuguese. But in the Asian countries, which is the next level, you have much more diversity of language as it comes. Then we have to break the spell, break the myth of nativity. So of the 47 million Hispanics in the United States, 67% were born here. So the growth in our community is not because of immigration. The growth in our community is because of birth rates. And then we have 33% that are foreign born. And this is the one issue that I wanted to spend a little more time on. So the work that I do, what I've spent the last 20 years of my life, the last 3 years with these two centers, is to make sure that we can build an infrastructure for anyone, regardless of limited English proficiency, to be able to access behavioral health services. And that means substance use disorder services and mental health services. And one of the biggest issues that we have is linguistic access. So research shows it takes 3 to 7 years to master a new language. So some of you may be bilingual. Some of you grew up learning both languages at the same time, which is the easiest way. But some of you maybe learned it, and you know how difficult it is because you have to spend the time and dedication to do that. Well, the census reports that 46.8% of individuals, foreign-born individuals in the United States, speak English less than very well. And that's problematic because when you're in crisis, when you are addicted, when you have a mental health issue, when you are suicidal, we revert back to our original language. If you've ever been in a foreign country and you hurt yourself, you immediately go back to English. If English is your primary language, you start asking, does anyone speak English? Same thing with this. And some people don't understand this because they say, well, you know, that same individual is my mechanic, you know, and the mechanic told me everything that was wrong with my car in English. And then they told me it was going to cost $700 because everything costs $700 when you go to the mechanic, no matter what it is. But that's very specific. And a lot of bilingual or people who are learning English are proficient in their job. So they'll tell you all the parts in the car and the engine and what's wrong. But if you ask them to give you directions or to express to you how they're feeling, they don't have the language, they don't have the ability to do that. So, you know, half of the foreign-born individuals in this country cannot access these services because the providers don't have the linguistic capacity. So when we talk about Latino mental health, and I'll use interchangeably mental health, behavioral health, substance use disorders, there is research that shows that immigrant Latinos are healthier when they arrive in the United States, but they become less healthy after acculturation. And some of those issues have to do with how this country works on the clock. Time is money. And you have these messages of discipline when it comes to time and the stressors of buying a home, buying a car, and you buy things on credit. Some of these things do not exist in places where many immigrant Latinos come from. So, you know, you save money and you buy the car or you build a house and you do these things instead of credit, but we're a credit-driven nation. So people here end up getting more stressed because of that. There's also, well, I'll tell you in a minute. So, but when we talk about mental illness by the numbers, the reality is that it happens to everybody, right? So you have 1% of, or 2.6 million people in the United States live with the schizophrenia. About 15 million with major depressive disorder, about 60 million with some type of mental disorder, 6 million with bipolar, and about 10 million with ADHD. And some research shows that 1 in 4 people in the United States, 1 in 4 during their lifetime are going to experience some kind of mental health disorder. Over the last 12 months, we've seen an increase on suicide attempts and on completion of suicides, people struggling with anxiety, depression, in double digits increases. And we haven't done much for access except telehealth. So we have more people now that were able to see therapists because of telecounseling and the laws and policies that have to be changed with that. But it's not for everybody, and it's not for every condition. And then you have issues of Latino substance abuse. So we had our own study in the agency that I ran that showed us that adult Latinos that came to this country only drinking alcohol or not even drinking alcohol, within 5 years, they were following the United States social norms, and many of them were getting into other drugs, marijuana, cocaine, opioids, and so on. For adolescents, was within 1 year. Because adolescents, especially in middle schools, you know, 6th and 7th grade, people are already offering you marijuana, cigarettes, and alcohol. So kids were exposed a lot faster, and the ones that would come into treatment were exposed and started using, and it became a problem in less than a year. We do have about 40% of Hispanics report past non-alcohol use, and 16% were current alcohol users. There was a study about the relationship between the general population's drinking and drug use habits and the Hispanic Latino population. But when it came to alcohol, what we realized, it was the same amount of alcohol, but it was just consumed differently. Where in the general population, you had more people that drank more frequently, but in Hispanic Latino communities, you had more people that binge drank, meaning 5 or more per session. I apologize, I think this slide is a little mixed up, but I'll go ahead and address the barriers in behavioral health. Migration stress is the stress related to displacement and disorientation. And this is what happens when someone picks up everything they own and they move to another country and they don't speak the language, they don't know the system. And the stressors that come with that, people deal with their stressors in many different ways. And acculturative stress, it accompanies adjusting to those new circumstances, the new cultural context. They say kids adapt faster because kids have to go to school. So, in pre-COVID times, when all kids were going to school, you would see that. You would see they pick up English faster. They start learning about navigating the systems a lot faster than the adults. Traumatic stress is related to what happened during that journey. Immigrants in this country, and it's another misconception, that the problem with illegal immigration is at the border. The reality is that there are many people that come in on airplanes with student and work visas, and those visa expires. They're also undocumented immigrants, but they don't raise any red flags. They don't stand in a corner looking for day work. So nobody pays attention. They may have a nice home in suburbia and nobody pays attention. So that has to be taken into account into how do we serve these communities, because they're very different. But if you do cross the border, if you come in through the border or you have some horrific conditions, then you have that trauma to deal with when it comes to seeking services. Language, as I said, is the biggest issue that we have. And I want to make sure that we are clear about this definition, especially the bottom two. People use them interchangeably, but they're not. They're extremely different. So when you talk about translation, that is the conversion of written text, a brochure, an article. But when you talk about interpreting, is the re-expression of the spoken message. So if we need to provide someone an interpreter to re-express what they're saying to the clinician, that's an interpreter, not a translator. And the important thing to address with this is to understand that we have issues of fluency. Fluency has 4 parts. You need to be able to read, write, speak, and comprehend. That makes you fluent in another language. If you don't do any of those, then you just do one of those or 2 of those. But if you do all 4, then you're considered fluent. And then attitude. Many programs don't want to open up their doors because they have this expectation that if you want services, you need to learn English. So that becomes a problem. And then in some organizations, people do have a serious issue with serving people that have accents. And true, some people have thicker accents than others, and it may be difficult to understand, but there are ways of navigating that. There are ways to learning how we're able to do that. These questions must be answered by the provider if they hope to serve individuals who speak other languages and those that have limited English proficiency. So today, it's really easy to find out the languages in your area through the U.S. Bureau of the Census. And even a faster way to find out what are the most popular languages in your neighborhood is through the school system. You go to your local middle or high school, and that is the fastest way to find out who moved into the neighborhood and what languages do we really need to start preparing for, right? Many organizations don't have a communication and language assistance plan, so they turn people away. If they use the language line, it's only to get some basic information, see if they need to be referred to a hospital. And not providing someone an interpreter, especially in facilities that have federal funding or in some state funding, it's against the law, but nobody's policing it. So today we continue to hear people being told, make sure you bring someone with you who speaks English. And, you know, if you're meeting with a clinician, you don't want your son or daughter to be interpreting for you, especially if you have private things to talk about. Do you train your staff? And notice in none of these things, I've noticed that, you've noticed that I said you have to have a Latino or a Hispanic. No, to be bilingual, you just need to be fluent in that language. In my agency, I had people from the Netherlands. I had people from the United States. I had people from other parts of the world that were not Hispanic Latino, and they didn't identify as Hispanic Latino, but they were fluent in Spanish or Portuguese, and they knew the culture, so our clients loved them. You know, there is an immigrant paradox. Immigrant adolescents relative to their US-born peers are healthier from birth. There's lower infant mortality rates, higher birth rates. They have fewer physical health problems. They're less likely to be depressed, less experience with sex and other risk factors like delinquency or violent behavior, and less likely to use drugs. We have acculturation associated with conduct problems. As I mentioned with the alcohol and drugs, there is also some of those behaviors in some of these huge schools that we have in this country. So you may start seeing delinquency or gang involvement in some of these. Now, acculturation has many positive issues, and they do help people move forward and reach their goals in this country, which they wouldn't be able to do in their home countries. English language preference is associated with substance use and cigarette use. And the Spanish language use is associated with Latinos who primarily speak Spanish with peers and family are less likely to use drugs. So we have this data, this information that is available to us. And but sometimes individual barriers, like how we collect information on individuals, or provider barriers, or even systemic barriers, keep us from providing these services. And then I wanted to throw in a little bit about cultural literacy. So, you know, you have health literacy is the degree to which an individual has the capacity to obtain, process, and understand basic health information. So even if a Hispanic Latino makes it to your center and you're working with a trained interpreter or someone in your agency that speaks the language, unless those individuals know substance use disorder and mental health language, the client is not going to understand what you're asking them to do. And then we have cultural literacy, which is where the clinicians need to understand where this client comes from. You know, what is the idioms, allusions, and informal content, because when the client explains their story, when they say what the problem is, the clinician needs to have some context with that. And often, unless they've done some homework or some study about this cultural literacy, they won't understand it. And this could be things like, I had a client who told me his addiction was because his ex-girlfriend put a curse on him. And he truly believed that, and he struggled with every step of treatment for the first few weeks. But that was his belief. So we had to make sure that we addressed him in a way that he would not stop treatment, but in a way that he would be able to understand what we were trying to teach him. Now, the good news is that there is a solution for all this. The Office of Minority Health has the cultural and linguistically appropriate services in health and healthcare standards, 15 standards divided in governance, leadership, and workforce, communication and language assistance, and engagement, continuous improvement, and accountability. So we have a roadmap that we can follow, and we use a lot of this information to help organizations understand what it is that they need to do in order to serve those communities that are unserved. You know, the one part about opioid use disorder that I want to make sure is shared before I end and we move to questions. This is not the first epidemic in the United States when it comes to opioid. The first one was in 1903. And then we had a second one in the 60s and 70s and early 80s. And many brown and Black people died during that. So it may not be shocking for you to learn that today, at the drop of the hat, we're giving out Narcan to many communities. You know, I do Narcan training here in Georgia for law enforcement and other first responders, and we give them Narcan. Well, we've had naloxone since the late 60s. So one of the issues I want you to think about is when you see these disparities, you know, what happened in the 70s and 80s when Black and brown people were dying from opioids, and we knew we had the opioid overdose reversal drug available to us, and it wasn't put out in the communities. Before we move into questions, in your slide deck, you're gonna have our contact information. Feel free to contact me after this. And this QR code and that link, I'm gonna put that link in the chat. So if you can click on that link when we're done and give us your opinion about this workshop, I would really appreciate it. With that, Chris, I can turn it back to you and see what wonderful questions this beautiful group has.
Okay, so first question to Alva Amwan.
Yeah, hi, I'm Alva Amwa. I'm a video journalist. I've worked for publications like the BBC, Christian Science Monitor, and the AP. I'm interested in what you had to say about US-born Hispanics faring worse with drug use than foreign-born as far as like their behavioral needs. And I'm just curious, it's more a two-part question. Where does Puerto Rico stand in terms of, you know, that spectrum of how well Puerto Ricans versus other people from Latin America fall within how well they fare with drug use? And what is it about the US that fuels this drug use? Is there a capitalistic element that, you know, maybe exists in the US that doesn't exist in these Latin American countries in Spanish speaking, this part of the world? Like what's really behind that?
Excellent questions. Thank you so much. Let me start with Puerto Rico. So I'm glad you brought that up, right? When you look at the opioid statistics in the United States and some big names, I don't want to put anybody in the stop, but it won't be hard for you to find them. Big names that have opioid statistics, they don't include Puerto Rico. You know, they don't have a Puerto Rico link or a Puerto Rico set of statistics. So how can that be? One of our biggest territories, right, is not included. Puerto Rico has a serious problem with opioids. They've had it for a long time, and they don't have the support that other organizations are getting here. But Puerto Rico does have a serious issue. Some good people down there working on it, but they don't have the resources that we have here. Now, why do we have a problem in the United States with drugs? The United States accounts for 5% of the world population, and we consume 80% of the illicit drugs, 80 to 85%. There is opioids, there are narcotics sold in many parts of the world, in Latin America, that you buy over the counter. You can buy codeine over the counter. You don't need a prescription. And you don't see the opioid epidemic killing 84,000 people a year in any country in Latin America, right? So why do we have that here? And that's, is both a philosophical question, but it's also an access question. The information that's coming out from the Attorney General suing the pharmaceutical companies, the top 8 pharmaceutical companies between 2006 and 2012 put out 100 billion doses of opioids in 6 years, 100 billion doses of opioids. So when you have that much access and you have this normalizing attitude that there is a pill for everything, when you break your finger, when you trip, when you cut yourself, there's a pill for everything. So you have the mentality since you're growing up that there is a pill for everything. And not to make fun, but in Latin America, 90% of the home care is Vic VapoRub, and people who are Latino descent in the audience, you'll know that everything is Vic Vaporub, and that cures everything. So there isn't this, straight jump into some pill that's going to help you feel better. And that is a national crisis, because we do have to, and I'm all for elementary school, introduce kids to meditation, introduce kids to mindfulness, introduce kids to how to relax without thinking, oh, mom takes a pill or dad has a beer, and that's how I'm going to relax. So that mentality has to shift in this country in order for us to start decreasing that. Thank you.
Okay, next question to Kyle.
Hi, sir. Thanks for making time. I wanted to ask you about how some of these experiences and the numbers you see differ based on geography within the United States. So whether it be from rural Georgia to urban Georgia, or the experience of those who might find themselves in the substantial minority. I'm thinking of a place where I reported in Vermont, where 95% of the community is white. Do you find access to services is tougher in some of those areas? I'm just curious about what you found with how these experiences differ within the U.S. geography.
So thank you, Kyle. Great question as well. At the federal level, the federal government gave every state a pot of money, right? So it's a different pot depending on some formula that nobody can ever figure out. But then it's up to the state how they're going to use that money, right? And some states are very progressive. They spend the money on treatment, on outreach, on making sure that the Narcan gets to the families or the information, and they have the right places for someone to come in and detox and then have connection to some other program. And in some places, there's more availability of treatment. The reality overall in the United States, and these are SAMHSA numbers, only about 10% of people that need substance use disorder treatment actually get it. That means we have 90% of people that need treatment don't get it. And part of that is because we don't believe treatment works, right? We don't believe treatment works because we shame people into their addiction, which is an illness. And we still, with all the evidence that we have, we don't view it as an illness. We still view it as a moral issue, a lack of character, a weakness. And we need to change that. We need to normalize the conversation about all of it, about mental health. There's nothing wrong with me saying I'm depressed, I'm going to a therapist. Same thing that if I break my arm, I'm going to go get an x-ray and put a cast on. Well, the same thing with addiction. And my personal story, on Friday, I will have 36 years of personal recovery from substance use disorder. And I'm very open since I first got clean or entered recovery. I'm very open about my recovery, because if I don't tell people, listen, at the age of 21, I got the greatest news that I had a fatal illness, but here was recovery. And the things that I've been able to accomplish in my life are amazing. I would have never even dreamed of some of the things I've been able to do. Right? So we have to encourage people to be open, that they are recovering from substance use disorder, that recovery is possible, that life can be wonderful. Like millions of people are doing it, but we're not sharing it. And then access, for example, I live in the state of Georgia. In the state of Georgia, health disparity is geography. If you live in the 10, 14 county metro area where half of the population of the state lives, you can get treatment, there's 1,000 places to go get treatment. But if you go outside those 14 counties, sometimes you have to drive an hour and a half to see a therapist. Or we had rural hospitals closed, so there's nowhere to go for detox, right? And then if you do find someone, then there's issues with insurance. Many clinicians today, I guess is the opposite of a benefit of telecounseling. Clinicians got full. So there were waiting lists, and clinicians started being picky about, if you have Medicaid, I'm not going to work with you because this other guy's insurance pays faster, or somebody's paying cash and that's the fastest, right? So access became also a problem based on coverage, and the states that did not expand Medicaid are having bigger problems than those that did when it comes to access. Did I answer your question, Kyle?
Well, I guess I'm curious specific, certainly those broad outlines are things we've heard about the experience, but I'm curious if for the Latino population, if, you know, the broad trend lines that we see in addiction overall shift dramatically depending on whether they're in a community that might have a big Latino population or one that doesn't, or rural versus urban. So I'm curious about how the Latino population's experience differs from the broader trend lines of the whole US population, I guess.
Got it. So, you know, Latinos didn't start being counted in the opioid overdose deaths until maybe 3-4 years ago is when they started showing up. And that's because of that accessibility issue. And I'll give you two examples. New Mexico has a very serious opioid problem. And New Mexico doesn't have a lot of treatment right now. They're working on opening up more treatment. Georgia only has about 10% of the population is Hispanic Latino, and there is no treatment here unless you speak English and you understand how the system works. Linguistically, for Hispanic Latino communities, treatment is very scarce all throughout the country. There are small pockets in New York, California, some in Florida. We have a few individual clinicians here in Georgia. Treatment access is extremely scarce for Latino communities, partly for language and partly for culture, because, you know, many of them don't understand the westernized method of counseling. And within Latino families, counseling can be, again, shamed and shunned upon. And so, but there are places, you know, New York and New Jersey, they have wonderful treatment programs for Hispanic Latinos. Rhode Island has a Latino mental health network. So I think towards the corners, you know, the New York, Florida, California, some of the larger Hispanic populations are better established than the rest of the country.
I appreciate it, sir. Thank you.
Thank you.
Okay, so we'll go to Madeline, then Barbara, then Cheryl, then Andrea.
Hi there, I'm Madeline Beck. I'm with the Mountain West News Bureau, so reporting for NPR stations in the Intermountain West. I was just wondering if you could talk a little bit more about the requirements when it comes to like federal funding with interpreters, and also whether you think technology might help bridge that gap, because I know that we're seeing so much more video conferencing and things these days.
Excellent question. Thank you. So, you know, the Civil Rights Act of 1964, I think under Clinton, it was determined that national origin also included language access. So it was mandated. And then there was an executive order by Clinton that individuals with limited English proficiency had to be provided with language access. So organizations are supposed to have a poster with about 20 different languages. And it says, if you speak this language, we can find you some help, right? So what happens is nobody's policing that. So people are being asked to bring someone, or they use someone within the organization with no clinical treatment, but only because they speak that language to come and interpret for the counselor. So there is, you know, our recommendation, of course, nothing beats one-on-one communication. So having a bilingual, bicultural clinician is the best solution. And, you know, we're working on 2 projects right now to increase the number of bilingual, bicultural clinicians in the country and preventionists. So in prevention, we also need to do this. And then, so technology can play a big role for, again, those life-saving, immediate information. But once you start talking and you really want to help someone manifest change in their life in order to improve their life, technology may be more difficult. With telecounseling for Hispanic Latinos, we're realizing, we did our own research at my agency, and we found out that 86% of the clients that were coming to see us had a cell phone, and 70% of those had a smartphone, and they knew how to use email and things like that, but they were not familiar with Zoom and with virtual meetings. So we did have a telecounseling program for Hispanics, and we had to put in place a how do you use this technology kind of program. So I would send a bilingual technician to that individual's home, and some of them were 100 miles away. So they would in person teach them how to turn on the computer. We would give them the camera and the microphone, so how to work that, and then sit with them for the first session, and then they were able to do it. So some people just don't have the know-how on how to do it. And the other one is bandwidth. So many Hispanic Latinos live in communities where there is not enough bandwidth to do this virtually, so they have to resort to either a telephone, and some are getting telephone counseling, and it's not as effective as face-to-face.
Thank you so much.
All right, let's go to Barbara.
Hi, yes, Barbara Morris. I work for the Navy Station in Providence, Rhode Island. Thanks so much for bringing up Rhode Island. I think we do have a very robust system in reaching out to the Hispanic community. But I have a two-pronged question. Do you think there's a bigger cultural barrier within Black and Brown communities as far as getting treatment? Don't talk about the problem, you know. And then the other one is, this might be off the charts, is there a country we should or could be modeling after, since we have, you know, the greatest burden of drug use in the world?
Wow, excellent questions. Let me start with that first one. There are barriers in Black and Brown communities. One barrier we share is the faith community. So many Hispanic Latinos are told to go to your priest and they're going to fix it. And I have many priest friends of mine who call me and say, what do I do with this, right? So at least they're calling, but the mentality is that you just have to go in private and tell your priest, and somehow it's gonna work out. So and then in the Black community, the same thing, you know, very strong faith community. You go talk to your pastor and you're gonna pray about it. So we've made a lot of headway in breaking those barriers, but it's gonna be on community education. Right? So we need to educate the community. So how do you educate Hispanic Latino communities? Again, you need to have a bilingual, bicultural individual that goes in those communities, gains the trust, finds out who's who in that community, that can set up a meeting in the evening with daycare, with some food, so people can actually come out and hear what you have to say. And that's going to change the mentality. The reason I know that works is because when I started my agency, it was just me. And immediately I had 20 clients the first week, just because I was bilingual, bicultural. Within 5 years, I helped build 41 bilingual clinicians, helped them get licensed. We were seeing 150 people a day, right? So this works if we educate the community on how to use behavioral health services. It will work.
Should we be working with church leaders then? I mean, is that a way in?
Well, we should be working with everybody. We should be working with faith communities. We should be working with, the law enforcement community, the hospital community. Everybody needs to be a partner. The schools are one of the easiest way to get access, so we need to work with them. Your second question about what country we should be modeled with, I don't know that there is one country. I know that there are countries, as I mentioned, that sell narcotics over the counter and they don't have an opioid overdose issue. And again, it's that mentality that we don't always have to go jump at a drug. Now, there are some controversial solutions being used in other countries that the United States has been resistant to, like, needle exchanges or having the tents where people can safely go use their drug. And if they get overdosed, they'll be given naloxone. So those are models that we're seeing are working in other countries. And well, they're working in reducing deaths. And in some occasions, they're helping that individual get into treatment if the appropriate treatment is available.
Okay, next question to Cheryl.
Thank you, Dr. Mancini. Let me tell you, your presentation was wonderful, and you addressed so many issues that make us look at this and say this is a societal issue, because many of the issues that you raised are ones that other communities are dealing with. And I wondered if you saw an issue, because I'm also an educator, I'm with the Texas Metro News, but I also teach, and I found that I'm finding more and more of my students in Dallas are, their parents are actually discouraging them from speaking Spanish. And so that's an issue. And then there are employers who assume because your surname says you have that Latino background, they assume you speak Spanish and you actually don't. And that's been an issue. But so I'm wondering, how does it help the community when we can't just allow Spanish, those of Latin heritage, we can't just allow for them to be the ones spreading the message. And so this gets back to you talking about education, the amount of access that we have, and the people and their impression, and looking at lumping all Latin people into one category, you know. And for me, I'm looking at my own home that I have Mexican here, I have Puerto Rican here, and I look at where I came from, and I came from New Jersey, where they were, when I was growing up last century, they were primarily Puerto Rican. And then I moved to Florida, to Tallahassee, and they were primarily Cuban. Then I moved to Texas, and they're Mexican, and they're all different. And you have to understand that and respect it. And I think that speaks to America's disrespect of differences. And so as you deal with, and know you've had a lot of time, 36, I found that like people don't mention treatment centers here in Dallas as much as they do in New Jersey when I go home. And so we're dealing with so many issues. And how do you help when you have a society that still marginalizes difference and your socioeconomic background?
Well, it's like, how do you eat an elephant, right? One bite at a time. So we just have to keep pushing forward. We just have to keep carrying the message. You know, if we can help save one life, one family, we can do that. But you're right, it's a huge issue. It's a societal issue. And we just need to continue to bring the message that recovery works, that addiction is an illness.
Okay, and final question to Andrea.
Thank you, Dr. Mancini. I'm Andrea De Leon from NPR. You mostly answered the question that I was waiting with when you were speaking with Barbara, but I was specifically interested in whether you find any particular barriers to acceptance of MAT in the population that you are working with versus what you may know from studies of the population at large.
Excellent question. I'm so happy you asked that. So I'm sure everybody's familiar with what MAT is, medication-assisted treatment. We're using buprenorphine to help opioid use disorder, along with talk therapy. In Hispanic Latino communities, we're seeing very little or no use of MAT. One of them is the providers may have a language or a culture barrier to that individual coming in. But at a higher level, and I started working with Dr. Rios at the National Hispanic Medical Association. So for 2 years now, I've been planting seeds in her ear. So if you talk to her, help me here. That we don't have enough Hispanic doctors in the buprenorphine registry. So if most Hispanics try and go to a Hispanic doctor, especially if language is an issue, and if we don't have Hispanic doctors in the buprenorphine registry, even though they just expanded it, but we still don't have the other providers who are Hispanic in that registry, then we're not going to be able to use buprenorphine to help people with opioid use disorder. Now, will Latinos use it? Will they be on buprenorphine for 6 months or a year? I don't know. I don't think we have enough information for that. I believe they will, because if you explain to them what the medication is, they will adhere to treatment. You know, most Hispanic Latinos, regardless of acculturation levels, we do what the doctor says. You know, and the doctor said this, so I'm going to do this. And then you have your family, your mother, your sister, your wife, whoever, you know, drumming that into you. So it's not available in the way that it should be.
Okay, and with that, Dr. Mancini, I want to thank you very much. We're out of time.